join now.
Yeah, please.
Hello, good evening. Shall I share my screen?
No, Dr. Please wait.
Okay.
There will be a brief introduction, doctor, after this. After they introduce you, Lakshmi sir or Sudhir sir will introduce you, and then kindly share your slides.
Definitely, sir. Thank you.
The attendees have started to join.
Thank you.
I am here. Hello.
Sir, good evening.
I am joined.
Thank you, sir.
Thank you, sir. Thank you so much, sir. Thank you.
Support team.
मेरी
Again, I can't share the slide.
मेरे
I can't
डॉटर के
change.
फोन से ज्वाइन कर दिया. So are we
Sir,
starting?
Sir, Sudhir Shah, sir, we should congratulate Meshram also, sir.
Yes, I did. I mentioned him, but
Yeah,
he could not stop. So I will call him tonight.
And also we'll announce
now.
in this forum. Congratulate him for his Padma Shri, sir.
I will right now do it. Don't worry.
Thank you, sir. I just want to remind you.
Yeah, thank you.
Thank you.
Shweta, can you share the slide? Once I'm sharing, then.
Yes, sir.
Hi, Manoj. How are you?
We were lucky to see sir in Institute Rare Disease Conference also. Sir was chairing a very interesting session.
You were there, right? We met. Those two poor guys, how they were able to attend and hear all those things. Hello.
Sir.
Manoj sir, you start.
Okay. Sudhir sir, can I?
Yes, please go ahead.
Good evening, ladies and gentlemen. A very happy Republic Day to all of us. It's a very sacred day for all of us in India. A warm welcome to Secrets of Neurology. It's a knowledge feast for all neurologists. And today's topic is equally interesting. Acute meningitis with stroke, which will be presented by Grant Medical College and JJ Hospital, Mumbai. Next slide. Shweta, next slide, please. Shweta, next slide, please. And we would try to wrap it up by 9:30. Today, we would also like to warmly welcome our program director, Dr. Sudhir sir, and Dr. Lakshmi Narasimhan sir. And it's my honor and privilege to introduce our program director who needs no introduction. Shweta, could you go to the slide, please? All of us are very lucky that these two stalwarts have been spearheading this pulse. And today is episode more than 3 years has already passed with this. Professor Dr. Sudhir Shah sir is professor and HOD at prestigious SMT, NHL, MMC and SBPI MSR Ahmedabad. And sir is also director of neuroscience at prestigious Sterling Hospital, Ahmedabad. Many awards and accolades to sir's credit, but he has always asked us to keep it modest and brief. But I wouldn't fail in my duty if I don't say that sir was conferred with most prestigious Padam Shri in 2016. Dr. Sudhir Shah sir is also recipient of Dr. B.C. Roy Award. Sir is also recipient of UNO Award, and sir also did his famous research on prolonged fasting, which featured in 3 international documentary films. Dr. Sudhir Bhai Shah's interest is into stroke, neurodegenerative disease, and epilepsy. Sir, a warm welcome to you. And our second program director is equally having a lot of accolades to his credit, Dr. Lakshmi Narasimhan sir. Recently, sir moved from prestigious Madras Medical College and became director and professor department of neurology at prestigious Sri Ramchandra Institute of Higher Education and Research. Many awards. His contribution to the field of academics is par excellence. Paltusi Advisor, A.V. Vekar Award for Global Best Teacher, Best Paper Award by Anne. And he has been continuously serving the field of neurology both at the national and international forum. No wonder, because of these 2 stalwarts who are our program director, that this is the longest running web series in the field of neurology, 3 years crossed. May I request both our program directors to introduce the participants and discussants and the case presentations. Over to you, sir.
Thank you, Manoj, for those kind words. First of all, I want to wish you all a very, very happy, warm Republic Day. This is the 75th Republic Day India is celebrating, and this is our Amrut time, they call it. So I hope that, and we wish that India would really progress even faster in the coming years. We have witnessed wonderful milestones in recent times, and we are all happy about the progress of India at every front. Today, on eve of Republic Day, yesterday late night, we came to know that one of the colleagues, Professor Meshram, was declared to be the award winner of the prestigious Padma Shri Award, and our compliments and best of best congratulations to our colleague Dr. Meshram, who has served our community as well as represented India's neurology at the World Federation at several levels. And he has been continuously doing medical education for patients, doctors, and general practice at all levels. So once again, sincere congratulations from both of us, myself and Dr. Lakshmi, our whole team, that is Kintas team, and also on behalf of all of you and all of Indian neurology people. Now, I must congratulate all of the delegates who have participated in all these programs, and as it's been said, this is a continuously running program, one of its kind, most awaited, very well received program, and the structure and design of the program is such that all the residents, assistant professors, newly passed DM, DNB people, as well as junior and senior consultants, they all relish and enjoy and participate in this program, not only in India, but countries from near and far distances. So I compliment my course director, Dr. Lakshmi Narasimhan, for his incessant efforts also, and the whole team of INTAS headed by Global Cell Division, Mr. Chadda and his team. Today, the presentation is by one of the oldest medical colleges of India, Grant Medical College and JJ Hospital, Mumbai. And may I have the first slide? The topic is acute meningitis with stroke. First slide, please. The presentation would be done by Dr. Reshik Yanan K. And then who is MBBS MD from General Medicine and is DNB Neurology from Jaslow Hospital, Mumbai. Currently is an associate consultant in Fortis Hospital, Vashi, Navi Mumbai. He will present the case, including the history and some of the clinical aspects. Second, next please. Dr. Shashank Nagendra, Assistant Professor, Department of Neurology, Grant Medical College and JJ Hospital, Mumbai, would take this case forward, having the localization and discussing the differential diagnosis aspect. Dr. Shashank is a fellow of the Canadian Stroke Consortium expert. Is had a stroke fellowship at Calgary Stroke Program. Is a clinical observer in International Neurology at the Toronto Western Hospital. He had his fellowship in interventional neurology also at Grant Medical College. He is basically a DM neurology from the same hospital and college, that is Grant Medical College and JJ Hospital. He had achieved the Young Investigator Award at the World Stroke Congress in 2021, and he has presented numerous papers at national and international forums. May I have the next slide, please? And I must acknowledge that my friend, a very good colleague, Dr. Pawan Oza, accepted this invitation at a very short notice, just before a week or so. And I'm very thankful to you on behalf of both of us and the team. The case has been said is acute meningitis with stroke, and Pawan is a very well-known name in the Indian neurology. He is an associate professor at Grant Medical College Hospital, director of neurology at Fortis Hospital, Navi Mumbai, and he is DM, DNB, FCSP, and he had his fellowships also abroad. He was a DC member, Indian Stroke Association, President, Associate of Neurological Clinical Research, and ex-Secretary Master Association of Neurology. That is MAN. He is in about all 25 publications, and major honors are Jane Tata International Scholarship in 2010 and the gold medal in DM Neurology exam in 2002. So, Pawan would give final diagnostic comments and take-home messages. Next slide, please. So with that, I want to once again thank all the delegates, my co-course director, Dr. Lakshmi, the team, and of course, all previous speakers and participant colleges and institutes who have made this program tremendously successful. You know, to run this program over more than 3.5 years is not a joke. It's a very great achievement. And we wish to continue and participate in this program in the same way. If your participation, your enthusiasm, your encouragement, and your comments help us, grow further. So with that, I request Dr. Pawan Oza to give your opening comment and then start the proceedings. Thank you. Thank you very much.
So I think I'm very grateful to Dr. Sudhir Shah for his opening remarks, and I would say that we are privileged to have the company of Dr. Sudhir Shah here on this forum, and under his directorship, I think the way this program is unfolded and carry forward, it itself is a miracle. So, and knowing Dr. Shah personally, I am really blessed to have a senior and a friend like you. Thank you so much, sir. I am also thankful to Dr. Lakshmi Narasimham, who is a constant support and guidance at most of the places wherever we have difficulties, and he's always there for us. And this is the major force that has kept this forum going on for so long. And I wish the forum huge success in the future. And with that, I think the one case that we chose to present today is basically about a stroke that came in a patient with meningitis. What were the possibilities in the beginning? How the case unfolded? What were the challenges we faced? And what is the final conclusion and the outcome? It will be interesting to see as the case is being discussed by Dr. Rishik and also discussed by Dr. Shashank Nagendra. So I think we should, start that case after, we start the case just immediately, and then we take it forward from there. Thank you so much, sir, once again.
Thank you.
Thank you.
Hello, good evening, everyone. Dr. Rishik here. Shall I share my screen?
Yes, sir. Please share your screen.
Rishik's video is not there.
Just one second. I'll just. Hi, am I visible now?
Yes, better.
So, firstly, I would like to start with saying Happy Republic Day to everyone, and thank you for introducing me, sir, and welcome to all of you who are attending this meeting, because we are going to discuss an exciting case today. So I'll start with this patient is a 42-year-old gentleman with no comorbidities, was transferred to Fortis Hospital with fever, which was there for since 10 days, and it was a low-grade fever, and it was there intermittently. Also, there was a headache associated with the fever, which was there again along with the fever, which was mild, generalized, not associated with nausea or vomiting. And along with this, patient was also having some altered sensorium, which was a recent complaint, followed by fever and headache, where patient was drowsy. The relative said that he was arousable, but occasionally he used to become hyperactive. So this is the date on 16th of October where he was admitted in Fortis. Prior to, and there was no history of any motor weakness, no history of cranial nerve abnormalities, no history of sensory dysfunction or bowel dysfunction, no history of rash, joint pain, cough, breathlessness, abdominal symptoms, mainly to rule out systemic symptoms along with infection. So prior to the admission in Fortis, which was on 16th of October, we noticed that the relatives gave the history that he was admitted in a local hospital with fever and headache. He was evaluated for malaria and enteric infection and was started on antimicrobials. Also, we noticed that the patient became progressively drowsy, and then the patient was shifted to Fortis Hospital. Now, when the patient was in ER, we did this examination where patient was having a low-grade fever with a temperature of 100 Fahrenheit, and he was disoriented to time, place, and person. His GCS was around 14. There were no focal deficits on examination, but we found that the patient had some mild terminal neck stiffness. So with this examination, we thought this patient is having an acute presentation with fever and altered sensorium with some meningeal signs. We thought we would like to get an MRI imaging of this patient, and this is what we got. As you can see in the DWI sequence, that there is a right temporal, medial temporal tiny restriction diffusion with a flare hyperintensity in the right insular and temporal temporal lobe cortex. There are some sulcal hyperintensities. So with this vessel infarct, we did an angio also, which was looking normal to us. This was the report which they gave, where they showed that there is effacements of the supra-infratentorial cortical sulcal spaces, and post contrast there was some picture looking like meningitis, and as I discussed, there was a tiny infarct in the right temporal lobe, and the angio was normal. So we further went ahead with the investigations. We started evaluating with the basic, that is CBC, RFT, and LFT, which were normal. We did ESR and CRP, which are normal. Of course, we went ahead with the CSF study. Now, the CSF study showed a significant higher amount of cells, 259 cells, with predominantly lymphocytosis, 80% lymphocytosis, along with proteins which were elevated, and a remarkably low CSF sugar, with a CSF AD of 5.
Thank you for the presentation, Dr. Rishik. Just a pause here. So since we have a clinical history and the investigation, so at this point, would you just, for the sake of discussion, would you like to summarize the case and let us know what we are thinking?
Right. So I've summarized the case that this is how I summarized that this is a case of acute meningitis with a reactive CSF lymphocyte predominance with low CSF sugar and a tiny infarct. Here, as the patient presented with a meningitis, acute meningitis, where clinically also patient had some mild terminal neck stiffness, along with the investigations were showing highly reactive cells, where predominant lymphocytosis was seen, and an important point was a low CSF sugar. That's why I kept my possibilities as a partially treated bacterial meningitis. Then I would like to keep tubercular meningitis as my second AD and malignancy meningitis as my third. The explanation for this DDs are the first diagnosis which I wanted to keep bacterial meningitis is because of the highly reactive cell count and with an acute presentation. So that's why I kept bacterial meningitis in the first go. Second, I would like to keep tubercular meningitis because as we know that tuberculous meningitis is quite common in India, and this is a state where we can't differentiate between these two meningitis currently at this state. Malignancy meningitis I wanted to keep here is because of the one finding which I've got in the CSF study, that is the low CSF sugar, which could be seen in a patient with malignancy meningitis. So we further did investigation so that we could try to pick one of these differential diagnoses. So we went ahead with blood culture and biofire, which showed negative findings. Where the blood culture were negative, the biofire was negative, the gene expert pyrosequencing were negative in the CSF study, and the CSF cytospan were also negative. Can I proceed, Dr. Shashank, ahead?
Yeah, so thank you for letting us know what you were thinking. So yeah, so if you could just proceed with what treatment was given and how the patient went on to do.
Yes, Dr. Shashank. So in the coming slide, I'm going to explain the same thing, that as we thought of pyogenic meningitis in the first go, we started the patient on meropenem and vancomycin. We also started with steroids. And after we also noticed that the patient still had some fever with a low grade fever of 99, but the neurological response, that the GCS was very good, patient was awake and alert. Then what we noticed was that on 26th of October, that is after 10 days of admission, we noticed that the patient had a complex partial seizure. He had a partial seizure. We were shifted to ICU for further management. The reason why we shifted him because he became very drowsy. He was very drowsy.
Sorry, Rishik.
Yes,
your voice is not clear. Can you speak louder or probably come?
I'll keep my
Yes,
microphone close.
Yeah,
that will be better. Yeah, am I audible now? I think.
Yeah, better. Yeah.
No? Thank you, sir. So yeah, as this patient had a new onset of symptom, that is a complex partial seizure. Along with this, the patient was very drowsy. He was arousable, and also we found that the GCS was coming down, but there was still no focal deficit. We couldn't find any focal deficit. The patient was shifted to ICU with good amount of anti-epileptics. The seizures were controlled. Then over next 2-3 days, we noticed that patient had a new clinical findings on examination, that the patient had a right ophthalmoplegia with right eye ptosis, and we observed that the right extraocular movements were fully restricted. Patient was not able to move the right eye horizontally or vertically, and we also saw that the pupils were spared. The pupils were reacting in both the eyes. So this is the picture of the patient, image of the patient, where we can see that the patient with right ptosis. So here, as we realize that there is a new focal findings with preceding complex partial seizure, so there are new neurological symptoms and new neurological signs which we noticed. So we decided to do a repeat imaging here just to understand the process of the disease. So what we initially thought while assessing that, is there a possibility that the patient became drowsy because of the complications of the meningitis, or whether the tiny infarct in the temporal lobe must have evolved. So that's why we did an MRI imaging of the patient, and as we can see here, the temporal lobes bilaterally were slightly dilated, could represent an early hydrocephalus, and there were some basilar exudates as well. So this is the image where we did a DWI sequence, where we can see clearly that there are bilateral temporal lobe infarcts right now. There initially it was only a right temporal medial temporal tiny infarct. Now patient is having an infarct in the right left hemisphere as well, and also there is a new infarct in the medial anteromedial part of the thalamus. So we went ahead with the DSO of the patient. We noticed that, because as we can see that there is a vasculitis process, there are multiple tiny infarcts going on here. So we thought that is there any vascular process which is going on. So that's why we decided to do an angiography of the patient. And as you can see here, there are multifocal stenosis. Here is the right PCA stenosis at P1, P2 segment. There are some stenosis over the P3 segment as well. We also found some stenosis over the left NCA. So this was the finding which we saw in the DSA, that it was suggestive of a beaded appearance, alternate construction and dilatation involving right MCA, AC, and right PCA, and right superior cerebral artery. So again, here we had a picture of whether we are dealing with a vasculitis along with an infective process, meningitis with a vasculitis. So we thought of repeating the CSF of the patient, where we can see that the cells of that is the first CSF and second CSF, we compared it, and the number of cells were significant or almost same while comparing. But the important point is the sugar level were slightly elevated, and ADA was one report which came out to be positive here.
Certainly very interesting, Dr. Reshik. So as you told, that this is a progressive course where the patient is developing new symptoms and new imaging findings during the course of this infection, in spite of being on medication. So could you just summarize for our colleagues what has happened up till now and what we have done and where we are at with the patient?
Right, Dr. Shashank. I just have summarized here up till now that what we're dealing with a case of an acute lymphocytic meningitis, as we saw that there were predominant lymphocytosis in the CSF with complications of hydrocephalus, with basilar exudate, with ophthalmoplegia and vasculitis in bilateral hemispheres. So clearly in the angiography study also we found that the patient has a secondary vasculitis, and now possibilities of the secondary vasculitis, we thought of tubercular meningitis, fungal meningitis, and malignancy related. So we decided to further evaluate this patient so that we can rule out other causes of secondary vasculitis. So these were the causes of secondary vasculitis, but as we discussed right now that we are dealing with an infective vasculitis, or less likely but still a malignancy related vasculitis.
Yeah, just to highlight, there's there's a doctor in the comments who came out rightly say this is TBM with vasculitic infarct. But I think so far, did we have any evidence proving that it is tubercular, Dr. Rashid?
Apart from the investigations which we did, the second CSF showed a slightly elevated ADA. Apart from that, we didn't have a clear picture of TBM vasculitis here. So because the gene expert, the pyrosequencing were all negative. But again, the vasculitis with the infective meningitis with vasculitis can be seen in other causes where patient can have hydrocephalus, like fungal meningitis, where cryptococcal can also have some hydrocephalus, and also sarcoidosis is also a possibility where patient can have some hydrocephalus and meningitis. But still, the CSF picture with a highly reactive CSF where the cells are significantly high, sarcoid is almost ruled out with a low CSF sugar as well. So keeping TBM vasculitis in the DD, that's what we also thought. We kept TBM vasculitis in the list of our DD, and we further evaluated the patient. From further evaluating the patient, we did Monto test, we did CSF gene expert TB pyrene sequencing, which all came out to be negative. The CSF cytosine was negative to rule out malignancy related meningitis. The whole body PET was normal. Chest, CT, and abdomen were normal. CSF for fungal cryptococcal were negative. ESR CRP was initially normal, and this is to rule out non-infective causes of vasculitis, that ANA, C-ANCA, P-ANCA, APLA, and RA factor were negative. Serum and CSF waste levels were normal. Serum IgG4 level were normal. Serum Brucella also we thought of serum Brucella also during the course, which came out to be negative. And of course, HIV, hepatitis B, and hepatitis C were negative. So, shall I proceed further, or?
Yes, please.
Now, as we had a differential diagnosis of TB vasculitis, of course, it was there in the picture. And as we observed these important points, that the patient with meningitis with secondary vasculitis, which is a common feature in tuberculous meningitis, along with some hydrocephalus, which we saw in the second imaging, and this persistent CSF lymphocytosis. One more important point was elevated CSF ADA level, which was seen in our patient in the second CSF study. This is to highlight that the CSF ADA shows a 90% of specificity. And last thing is the progressive nature of the disease. So that's why we didn't wait for a strong evidence of tuberculosis. We decided to start the AKT for the patient. Now, this is a short review of literature for TBM vasculitis, where cerebral infarction can be seen in 2/3 of patients with TBM, tubercular meningitis, and they're associated with poor outcomes. Infarcts are common in perforated arteries of the anterior and posterior circulation, and autopsy studies also showed an extensive vasculitis in TBM with in proximal and distal arteries of the circle of Willis. So important point was that macroscopic infarcts are more in the anterior vascular territories and microscopic infarcts are more in the posterior vascular territory. This picture, this image shows, I would like to highlight the importance of this image, where we can differentiate between the TB zone area and the ischemic zone area here, where the caudate nucleus, the anteromedial part of the thalamus, and the anterior limb of the internal capsule are more commonly affected in TB related vasculitis, whereas the putamen, the posterior limb of the internal capsule, and the posterior part of the thalamus are more going towards the ischemic zone. Now, coming to pathogenesis, pathogenesis of vasculitis contains are two types. There are two types of mechanism for the TBM vasculitis. One is direct invasion and the other one is immunological injury. The direct invasion is the more common one, where the basal exudates itself affects the vessel wall of the circle of Willis, leading to stenosis and thrombosis. And this is a picture which shows multiple infarcts over the DWI sequencing. That this is more like a direct invasion mechanism of vasculitis and TBM. Whereas immunological injury related TB vasculitis is more of immune complexes, where the deposit of tubercular protein immune complexes are deposited over the small vessel walls, leading to inflammatory changes. And it is also possible that the antibodies are formed against the antigens of the Mycobacterium tuberculosis. So the important point which I would like to highlight here is these two tiny infarcts which I have encircled. These, as we discussed in the earlier slide, that they are coming more in the ischemic zone area. Although this tiny infarct in the thalamus is more goes towards the TB zone area because of direct invasion of the basal exudates. But here, these are more related to immunological injury, which I just discussed right now. Now we go further ahead with the course of the patient in the hospital, where as we decided to start AKT for the patient. So we started with modified AKT or hepatosafe AKT, where patient was started with amikacin, ethambutol, linezolid. High dose of dispirin was started, 325 mg TDS, and a dose of dexamethasone was increased with 8 mg TDS. Also, we started patient on thalidomide later because after 3 to 4 days, after 4 to 5 days of AKT, we realized that patient was having intermittent fever spike and the hydrocephalus still persisted. So we thought of adding the thalidomide here. And day 7 of AKT, we decided to repeat a CSF here. And here in this table, I would like to highlight the course of the CSF studies which we did of the patient. As we saw on the 18th of October and 26th, that is the second CSF, where the patient developed new focal findings. There were highly reactive CSF with predominant lymphocytosis. Whereas on day 7 of AKT, there was some improvement which we could see here. The number of cells decreased. The proteins were still high on the and sugar.
Excuse me, can you speak a little loudly, because it's not that clearly audible. So please, slow and loud speech, please.
Yes, sir. Yes, sir. Am I audible now, sir?
Yes, almost, but
Yeah.
you can try a little more. Thank you. I'm sorry for interrupting.
No problem, sir. Thank you, sir. Thank you. So, as I was saying, that the sugar level were also an important finding which we noticed throughout the course of the patient, where initially the sugar level were 12, then there was some slight improvement to 16, and a good amount of improvement was seen in the sugar level, that is 44, after 1 week of AKT. And incidentally, we noticed that the culture came out to be positive for Enterococcus faecalis. So in view of this culture report and an ongoing fever which was still there, we started the patient on daptomycin. Though we thought there is a possibility that this could be related to nosocomial infection, the Enterococcus faecalis, because the initial two cultures were negative, but still we started the patient on daptomycin because of an ongoing fever, along with AKT and steroids. So after 1 month of AKT, we observed that the patient was improving clinically. The ophthalmoplegia started resolving with no fever spikes. The sensorium improved significantly, and this is the time where we thought that the patient is improving, and we thought that this is the time where we could plan discharge for the patient. This is the time the patient needs to leave, because neurologically, clinically, and in terms of CSF also, patient was significantly improving.
Dr. Rishik, if I may
Yes, sir.
just interrupt in between.
Yeah.
So
Yes, sir.
there are, this looks like it's a pretty straightforward case of tuberculosis with meningitis and all those complications and some infarcts, right? Now, do you think that when this Enterococcus faecalis came positive, were
Right.
you surprised, or like because till now we did not have any diagnosis, lab supported diagnosis of TB.
Right,
And
sir.
also we had just one ADA and the clinical picture that the hydrocephalus and all those things coming, and it could
Correct,
have
sir.
been, there could have been multiple DDs, and one could argue that this is not proven TB, So do you
Right, sir.
think that Enterococcus faecalis, it turned up as a surprise, and did you still think about it, although you treated it? So what was it like? What were your
So,
thoughts?
right, sir. So definitely, it was a surprising element, the Enterococcus faecalis in the culture, and because, as you mentioned, sir, we throughout the course of the patient that clear evidence of TB was not available here, and with an ongoing fever after starting the AKT also, intermittently patient was having some fever spike, and then the CSF culture showed Enterococcus faecalis. So we went through the literature. We tried finding out whether Enterococcus faecalis has some CNS involvement. So I went through some literatures, and we found that Enterococcus faecalis, they do have a CNS involvement. They do present with meningitis with some vasculitis, but it's a very rare condition. And we also found that patient with Enterococcus faecalis, the typical MRI image of those patients are predominantly affecting the basal ganglia, and some temporal lobe meningitis was also seen in some of the patients.
And
So
also the presenting this WBC count, I thought that it was around 22,000.
yes, sir, it was
Which I think
22,000.
by itself, and you were initially thinking of a partially treated pyogenic meningitis.
Right, sir. Right, sir.
So because you discontinued the antibiotic, and then this third CSF came positive. So I think one cannot completely disregard, but although the general feeling is that this is a nosocomial infection, but we cannot disregard that 22,000 count when the patient came in, and he was
Agreed.
fever and meningitis. So I'm not sure, but let's go on anyway. Yeah, thank you.
Yes, sir. So on 10th of December, there were new events that the patient developed a progressive drowsiness over a few hours with a left faciobrachial weakness and a focal seizures. When I saw the patient on this date, so as we discussed that we were planning of discharging this patient, then when I saw the patient, I saw that the patient was not able to lift his left upper limb. He had a power of around 1 to 2 by 5 and a severe facial weakness. Also, after I would say 30 minutes to 1 hour, he started having focal seizures, and immediately he was shifted to ICU because his sensorium was also affected. So clearly there was a new neurological clinical thing happening here. So we decided to do MR imaging of this patient, and as we could see that the patient had a new imaging findings with a watershed infarct in the right MCA territory, along with a significant stenosis over the right MCA branch. So now, as we saw this new findings in the patient, where there is a new infarct, and also in the initially over the next 2 weeks of the admission, we saw that the patient had a vasculitis, and we are dealing with vasculitis. We thought we should repeat angiography and observe the process of the vasculitis here. This is what we found. There were significant stenosis here, as we can see some stenosis over here, over the right MCA. There was stenosis. This stenosis was seen in the previous DSA as well. Left PCA, right PCA territory, and there were some stenosis over the ACA territory as well, and distal branch of left MCA. So this is the report of the DSA, the second DSA which we did, which showed multifocal narrowing in right MCA, left ACA, and right PCA. So again, we realize that there are a new set of vasculitis process again happening here, despite of adequate treatment. We thought of TBM vasculitis. We still think of TBM vasculitis. We started the patient on good amount of steroid, dexamethasone, and AKT. So we again repeated the CSF study just to observe whether what is the trend of the CSF, because as we discussed initially that the trend of CSF study was on the improving side. So here we are. As we can see, comparing the CSF after this new onset infarcts, there are still decreased number of cells here, 45 cells compared with the initial cells, that is 101. And also the CSF sugar improved significantly.
Yeah, Dr. Rishik, thank you for the presentation. So again, after these events where there was worsening vasculitis and then new imaging findings on the angiogram, what was the thought process that was going on? Because this is now a patient who had already recovered after some neurological deficits and has now developed a kind of a new progressive drowsiness in spite of AKT and antibiotics. So what were the thoughts, and would you like to summarize things up till this point?
Yes, sir. Right, sir. So as we can see that the clinically patient was improving with the ptosis and the ophthalmoplegia.
Rishik,
and
Rishik, you are not loud enough, you know.
Hello.
Yeah, you're not loud enough.
Hello.
Yeah, please. Sorry.
Yeah.
Yeah.
So, no problem, sir. So as we saw the whole course of the patient, that the CSF, the clinical scenario, and the neurological thing were all on the improving side to an extent that we were deciding to discharge the patient. Now is something where we saw an vasculitis thing which is coming up, which is a worsening vasculitis despite the CSF showing an improvement here. So I would like to summarize this by stating that this is a case of tuberculous meningitis with hydrocephalus and cranial nerve paresis with an improving meningitis, but a worsening vasculitis. So this, because both meningitis, vasculitis, hydrocephalus, and the cranial nerve paresis are all complications of the tuberculous meningitis. But this one complication of vasculitis, this is clearly worsening, which we could easily see here. So we started thinking a little laterally, and as I would like to first summarize again everything, that this is how patient presented initially on the date of admission with fever with altered sensorium. MRI was started showing right temporal infarct. CSF cells were significantly high, sugars were low, DD were pyogenic meningitis. Then the new deficit of rhitosis and ophthalmoplegia with new infarcts in the MRI, bilateral infarcts, and exudates with multifocal stenosis on DSA. Cells not significantly, nothing major change in the CSF, but though we had a diagnosis of secondary vasculitis here with TBM, then we started seeing that the patient started improving. Though there were mild hydrocephalus, but clinically patient was improving. And clearly the CSF picture was also showing some improvement, good amount of improvement. So here is a new event which I am describing again, the left facial weakness, the MRI, new infarcts, and the DSA with multifocal stenosis. So I realized that we are dealing with something where a vasculitis is behaving a little different from the meningitis here. Because then we had an etiological possibilities of vasculitis, because clearly the meningitis, we started the patient on AKT. We saw a good amount of improvement, but the vasculitis is one thing which was disturbing us. So what are the etiological possibilities of vasculitis we thought of? And this is what we initially thought, though TBM vasculitis should be coming up. And second, what we thought was primary CNS vasculitis triggered by an infection. So here we thought of primary CNS vasculitis as our second DD, because as we know that we initially thought of secondary vasculitis. We ruled out each and every causes for secondary vasculitis. We thought of TBM with vasculitis, secondary vasculitis, we treated it. But now as we could see that the vasculitis is behaving different from the meningitis, we thought of primary CNS vasculitis as our second differential diagnosis, probably triggered by an infection, the CNS infection which he presented with. So the further course of the patient, where we thought of primary CNS vasculitis, and we started patient on pulse steroids, 5 days of pulse steroids and followed by oral steroids and mycophenolate mofetil. The next day of the treatment, we saw that the patient, after the first dose of IV steroid, the sensorium improved. There were no episodes of seizures, and after 5 days of pulse therapy of steroid, we saw a significant improvement in the limb power with the 4/5, and patient was wide awake and alert, and to an extent that we shifted the patient towards. So recently the patient came for follow-up after a month on oral steroids and MMF. And I would like to play this video. I will just yeah. I'm sorry, the video is little vertical here, but we could see the right eye here. The right eye has improved significantly. There is hardly any ptosis now, and the ophthalmoplegia is also improving. It's improved significantly. So after coming up for the follow-up, we had a final impression.
So again, your voice is low, If you can kindly
Hello.
speak louder.
Yes, sir. So really sorry. Yeah. So again, the final impression here, we thought of TB immune-mediated vasculitis and primary CNS vasculitis triggered by infection. This impression this impression we thought of this after the patient coming up for follow-up in our OPD, when as we saw in the OPD that the video that the patient has significantly improved in terms of ophthalmoplegia and the limb power, and he is cognitively very well. There is no higher mental function involvement currently.
So shall we stop here? Yeah.
So-
Shashank, do you want to give your comments? Then I will also give my comments.
Yeah, thank you, Dr. Pawan sir. Yeah, so progressively we have noticed that this patient is having very, very tumultuous course within the ward where there has been new findings. And the point where we started AKT, the patient did improve for a period of time when there was another event. And now, following that, the patient needed immunomodulation, and with that, the patient has finally improved. So one of the points which was well made is that the infection has taken its course while the vasculitis is in some ways still active, even if the infection has been controlled. Right? I would like Dr. Pawan Ojha sir to comment more on this.
Yeah, so basically the way I see this patient is he began with excuse me. Sorry. So the way I see this patient is basically this patient started as a strong suspicion of a partially treated pyogenic meningitis, right? But at the onset only when he presented, there were infarcts. So that means that there was a process of vasculitis right from the beginning, and there is no harm in saying that he was a tuberculous meningitis with vasculitis from the beginning. Then we have treated with whatever is required, and TB meningitis, as we always do, with the anti-inflammatory dose of Disprin as well as Dexa, and then subsequently also added thalidomide. So this takes care of the inflammation and the basal exudates and the basal infarcts that patients get typically, and that those are the typical vasculitis that we saw. So the point of presentation here is that TB vasculitis can be of two types. One is because of direct invasion, which causes the basal exudates because of the basal exudates and in the classical TB zone. And the second type that has been described, that is a immunological mediated injury to the larger blood vessels. So these two, they behave completely differently, and there were the immunological mediated injury is almost similar as we have an infection triggered primary CNS vasculitis. So the point to make here is that we treat that large vessel vasculitis, which is because of an immunological injury that behaves differently and doesn't go hand in hand with a meningitis outcome, and that behaves separately. So it has to be treated separately, and that is why we gave high dose of methylprednisolone and chased it up like a CNS vasculitis, maybe primary CNS vasculitis, which was triggered by that infection. So these are the points to make here, that we should not just rely only on Dexa and Disprin for treating this kind of vasculitis. And there are some case reports in literature where they have given in these patients immunologically mediated injuries, they have given IVIG, then IV methylprednisolone, also gone ahead with cyclophosphamide in these patients. So no need to just stop at Dexa or thalidomide and Disprin. And so here, these are the points that, the vasculitis behave completely differently from meningitis. And I'm also aware of some people who would call it as a paradoxical worsening, or some people will call it as a iris. But frankly speaking, we know that this paradoxical worsening is an immune mediated injury. And that is what we are pointing to. We are giving a name to the same thing, which is called as a paradoxical worsening. And this is not iris because the infarct started much before starting the AKT. So that vasculitis is not a part of the iris. This is a completely different. So these are my thoughts, and I think we have a discussion here. AKT was not stopped because the meningitis TBM. It is a case of a TBM, but the only point is that this vasculitis behave differently from the regular TB vasculitis that we have, and so that is why that was treated differently. They had a different outcome. Any other thoughts, Shashank, Rishik, or
Presentation, Dr. Pawan. There are a few questions. I just wanted to
yes,
open the
sir.
question box.
Yes, sir.
What is the role of thalidomide in TB vasculitis? Dr. Ashutosh Mishra has asked.
Yes. So we had a patient where we have had a acute inflammation going on, and to prevent, he had only one tiny infarct to begin with, and few infarcts. So we were not sure in the initial part when we started DEXA and we started Disprin, and he was showing infarcts. So we were not sure. We had some discussion, and this topic of thalidomide came. So we gave thalidomide at that time. We were not sure how much with force we would like to go ahead with the immunosuppression, because he was having cross infections. He was having GNP in urine, and he was also having later Enterococcus faecalis and all those things. So when he deteriorated the second time with a new infarct in the right MCA territory, then we had a lot of discussion with rheumatologist, ID specialist. Everyone was on board. And once we said that the infections were cleared, then we decided to give him Solumetrol when he had this stroke.
Okay. In fact, thalidomide has a better role in the cousin Mycobacterium leprae on the inflammatory exacerbation of lepra.
But it is also recommended in.
What I'm trying to tell is this.
Yes.
Definitely it is definitely a very powerful anti-inflammatory drug.
Yes.
In case of both Mycobacterium, both leprae and Mycobacterium tuberculosis, more so with the leprae, because as all of you know, that the behavioral pattern of leprae and Mycobacterium tuberculosis, even though they are very close cousins,
Yeah.
they are different. So, and the thalidomide, what the thing is postmenopausal and men.
Yeah,
those two characteristics the postgraduate should remember.
Absolutely.
Remember the disastrous thalidomide village where the pharma is still paying out through their nose.
Yeah.
So the next question is, why did you not start the usual AKT drugs of HRZE initially?
So he had liver toxicity when we started. He developed liver toxicity.
Okay, so hepatosafe drugs were started. Okay.
Yes.
Okay. One more. The third question is this is an anonymous attendee. There's one more anonymous attendee question. Are you still giving him ATT?
Yes, sir. So he is being treated as TBM, and he is being treated as vasculitis because of TBM or whatever it is. So we are treating him for two separate diseases which may be linked together.
Last question again by an anonymous attendee. The ATT in combination with an immunosuppressant, is it a safe combination?
If the patient is already responding to TB drugs, we have a lot of these myasthenia patients who develop TB. So we give immunosuppression at one point and also give EKT also. So once the patient is stable, then you can give, sir.
Okay. I think most of the questions have been answered, and my hearty thanks to Dr. Pawan and his team for an excellent presentation. And still, tuberculosis is still the tuberculosis meningitis, tuberculosis vasculitis are still a challenge. In each case teaches its own lessons. So I should, my hearty thanks for bringing out such a wonderful case in this forum. I'm sure that this case would open up the postgraduates' minds that each case of tuberculosis is very, very unique. And at this forum, on behalf of me and Professor Sudhisha, again congratulate Dr. Chandrasekhar Meshram, one of our colleagues, for receiving the prestigious Padma Shri. And over to Professor Sudhisha for the conclusion comment.
I mean, coming back to the case, I'm sorry for that, but the CSF sugars were consistently low. So in the primary CNS vasculitis, how many % of people have consistently low sugar? So why do you really want to that possibility of primary
No, no,
serious
no.
vasculitis still?
So I would like to answer this question, sir. Basically, there is no denying that this patient has tuberculous meningitis. What point we have made is that this vasculitis is not the regular TB vasculitis that we see, which is involving the base of the basal ganglia region, and which is classically defined. So the large vessel vasculitis, which has overshot the TB, when the TB has completely responded, the ophthalmoplegia has gone, the patient has become afebrile, then that time the TB is still going on. So there is no doubt that this is TBM, but the vasculitis is behaving different. So we have just proposed that either this is a TBM vasculitis with an immunological injury to the blood vessel, or it is a primary CNS vasculitis in addition. Most likely the first one. That is what we said, that our first impression is this is a TBM with vasculitis of a different mechanism. And that mechanism is not by fibrosis, by the exudates and direct infiltration by the bacteria, but it is an immunological injury, and that has been proposed to be, according to the many of the published literature, that the bacterial antigen, mycobacterial antigen, against that antibodies are made, and that is why this immune complex deposition is there in the major blood vessels. So that is why we treated separately.
All right. Did you have any data on CT, neck, thorax, abdomen, or any other lymph glands, or where you can do some biopsy and find out whether there is a tuberculosis? Because neither tuberculosis we have confirmed in this case, except for mild ADA raised, that too once 11.
And the hydrocephalus and the basal exudates, and in response the patient is recovered completely, sir.
So that is a clinical observation, but we have no pathological or genetic proof for the tuberculosis. Like the Genex is also not present, right?
Absolutely, I agree. So here, this is an unusual case, and that is why we have presented this in the forum.
No, very interesting. I am completely in concurrence to what you say, but the dilemma is unresolved as yet.
Yes.
Whether you call it tubercle and AKT has helped him or not, we don't know. What has turned the table is your Solumedrol and MMF according to the history that you are giving. Right?
No, but that is 1 month later, sir. So this patient was in the hospital for 2.5 months. So in the first 15 days, he got the ophthalmoplegia, basal exudates, everything. Then we started on AKT, and all that improved over 1 month. So he was completely all right, planned to be discharged. And then the vasculitis worsened. So the meningitis and the basal exudates, everything has improved, sir, on AKT.
In our
I understand what you are.
Yeah.
That's the same problem is with us also.
Yeah.
That we don't have a tissue diagnosis, because even in the PET scan there was nothing. No biopsyable tissue was there.
Right. In our DM days during my time, we had occasional cases of giant cell arteritis or Takayasu disease, which
I was about to
tuberculosis.
So I was about to tell that even now we give a trial of ATT for Takayasu and
so that's a very funny thing.
So we had done a PET scan for that, and we have done Dopplers also. So all that we have done. That is what we showed, that we have investigated this person in detail. Unfortunately, nothing has come positive, but he has responded to AKT. In between that, Enterococcus faecalis also came positive, confused us a little bit more. But that was thought to be like a nosocomial infection, because it came positive in third CSF.
Yes. Sir, one point I just wanted to add, sir.
Yes, sir.
See, the von Willebrand's factor is from the surface of the vessel wall. Okay, so it's a very good. In my practice, I have found that when I have a doubt whether the vessel wall inflammation is there or not, I use the von Willebrand level factor. Among there are various biomarkers for the vessel wall, but I've always been found that von Willebrand factor level was very good in identifying the vessel wall inflammation in case of any vasculitis. It's non-specific, but if you think that the vessel walls are inflamed, you can do this test, and then this will be a very useful biomarker. This is for the sake of post-diagnosis.
So I have two questions. I have two questions, just as a guidance. So clinically, definitely we are calling him as TBM, and we are calling this as a the immune mediated vasculitis. But once the patient has recovered on treatment, it has been now 3 months from onset, practically over 3 months. So now we cannot go back and do any biopsy. So I think should we still call him TBM, or we should, how should we go ahead?
That's what I was going to raise the question. If you can do still a meningeal biopsy, meningeal artery biopsy, probably it, if it is positive, it will give a great idea. Second thing
They
is
completely refuse, sir. Any biopsy, they completely refuse. The family completely refused anything.
any IgG4 levels you have done here?
That was negative, sir.
Okay.
Sir,
So I
in
didn't
ge-
see that in slide.
Sir, in general, tuberculosis prefers the perforating arteries. That is why, mostly in tuberculosis vasculitis, we see either it's a paramedian branches in the basilar or a lenticulostriate branch producing an hemiplegia. Most often, tuberculosis prefers its enemy to be very small and perforating. But the moment the larger vessels start getting involved in tuberculosis, it is always, I had a gut feeling, as I agree with Pawan, that it is a secondary autoimmune process triggered by the tuberculosis. That's what so the larger vessel, once it starts getting involved in a case where you are treating tuberculosis, I think it's a secondary vasculitis triggered by autoimmune process.
So then we need to treat it like that, sir.
Yes, sir. Yes.
Not rely
That's
on aspirin and Dexa. That is the whole point, sir.
No. The moment the larger vessels starting involved, you go flat out treat it like a vasculitis.
So that's what my starting question was, Dr. Pawan.
Yes, sir.
If we have some data on primary CNS vasculitis involving large vessel where you have low sugar as one of the manifestations, then ATT does not come into picture to some extent.
There is nothing like a low sugar in CNS vasculitis. This low sugar is because of an infective agent. That is what was our theory.
Yeah, so I think there are only two theories, and therefore the theory of infection-induced secondary vasculitis is gaining momentum in this particular case.
Absolutely, sir.
Otherwise, if there are any data where you get low sugar in primary CNS angiitis, then if you have some, I think we'll have to search, and I'll myself find out and tell you, then probably the matter is different. Otherwise, you are absolutely correct that tuberculosis in this case has triggered acute immune vasculitis involving larger vessel.
Absolutely.
Tuberculosis, though, is not confirmed. Clinically, it looks like, or maybe some other agent who is involving the basal systems and all that kind of, but we couldn't, and that he responded to all this. So otherwise, fungus, and otherwise, if it would have flared up without proper treatment. So I think
my submission to you, sir, is that because the basal exudates were there, hydrocephalus was there, that is why the primary diagnosis was not just primary angiitis of CNS. There was a because primary angiitis of CNS will not cause basal exudates and hydrocephalus. I mean, let alone the sugar problem, but because all these complications came, so the diagnosis is not just. So our final conclusion, as you rightly said, was that this was an infective agent which did this basal exudates also and hydrocephalus, and also triggered an immune response in the vascular system.
Yes, sir. Yes, agreed, sir. So, sir, one more worthy point to remember is I recently had a patient who went to European tour and stayed on the foothills of Alps, came back with a meningitis with a glucose level of about 1620 consistently in the CSF. I never knew that severe CSF hypoglycemia is characteristic of LCM, lymphocytic choriomeningitis, produces the most severe CSF hypoglycemia is produced by LCM virus.
Yes.
So yes. I learned only after that. Then we tried to get the PCR for LCM. We were not able to do it, but it's a self-limiting and settled. So European travel near Alps and low hypoglycemia, you should always keep the LCM also in your differential. Thank you.
And just putting a last remark. So if tuberculosis is known to produce small vessel diseases, tubercular arteritis is what we call is a perforating artery disease.
Yes, sir.
TB has with this proposition or this hypothesis, now we know that TB can either produce classical standard small vessel involvement, inflammatory vasculitis, or
Yes.
when it involves large vessels like this, then you have to go for this escalated regime. That is what it appears. So you have to be
Yes,
watched.
sir.
So
That's
that
what
is
I know. So
probably-
that's what I normally do, sir.
Yeah.
Thank you.
Thank you,
Thank you.
Pawan, for bringing up this wonderful discussion. And this is the purpose of this kind of meetings, so that the thought process is really evolved in all
It's
young
sharpened. sir.
and old scientists. Thank you very much, and thanks on behalf of the team of Secrets of Neurology, including myself, Dr. Lakshmi, Chadaji, and entire Globocell team, for the JJ group for presenting this case at a very short notice once again. Thank you very much, and happy Republic Day to all of you once again. Thank you.
Thank
Mr.
you.
Chadda, it's now set for you.
Thank you very much, sir. Today, on this auspicious day, as we commemorate our 75th Republic Day, we also embark on the 43rd session of Secret of Neurology. So happy 75th Republic Day to all of you. On behalf of Intas Pharmaceutical, I, Arun Chadha, extend the heartfelt gratitude to all our esteemed delegates for joining us on this momentous journey over the past 43 months. I would like to thank our Honorable Course Director, Dr. Sudhir Shah sir, and Dr. Lakshmi Narasimhan sir for designing such a fantastic web series on neurology, which is very helpful to all the DM and DNB students. We extend our sincere gratitude to Dr. Rishik Kannan, young neurologist, for their insightful case presentation. And we would also like to express our appreciation to Dr. Shashank for their meticulous evaluation of the symptoms and investigation. And our special thanks goes to Professor Dr. Pawan Oja sir, the Associate Professor of Neurology at Grant Medical College, Mumbai, for gracious sharing their valuable experience with this case and providing the crucial learning point and proceeding of this unique presentation. Once again, we are very thankful to all of you for your gracious presence. It's been a pleasure being with all of you for today's 43rd session of Secret of Neurology. Thank you all for your presence, and we will meet again on 23rd February with yet another most awaited next session of Secret of Neurology. Till then, stay safe and take care. Thank you. Thank you, sir. Thank you very much. Thank you, sir.
Yeah, thank you, everyone.
Thank you. Sport team.